Good evening. Today we'll discuss about infectious disease in children. So we'll discuss first disease here is measles. Okay, so this question can be asked in your university examination short notes and for even for MBBS and also for MD Pediatrics students. And measles is a very important topic even for NEET PG entrance examination. So we'll see the main points that you have to write it in your short notes or in your detail. Next in your what are the points that can be specifically asked in your NEET PG entrance also. Okay, so first it is a single stranded RNA virus. So this is a single stranded RNA virus. Okay, it belongs to the family of Paramyxoviridae. It belongs to family of Paramyxoviridae. Okay, so whenever you talk about a disease, a virus or any bacteria, you have to know its mode of entry, how it enters our body, human body. Next, you have to know about its pathogenesis and the pathology. Next, what is its clinical features, the treatment and diagnosis. These are the important points you have to note it down in your every questions of infectious diseases. Okay, so next, mode of entry. Mode of entry is through droplet. Next, portal of entry. How it enters our human body. Portal of entry. It enters through the respiratory tract or it can enter through conjunctiva. Okay. Next, what is incubation period? Its incubation period is between 8 to 12 days. In a simpler form, 8 to 12 days should be remembered. It is mainly should be remembered for your 1 mark question, MCQ questions for your NEET PG entrance. 8 to 12 days, you can in your short notes you can write it as 1 week, okay, or 1 to 2 weeks. You remember it like that. It is 7 to 14 days, 1 to 2 weeks. You can remember that way. But for NEET PG specifically, if they ask, you have to write it as 8 to 12 days only. Okay. And in another one more point here, for measles, human are the only pathogenous human. Okay. Next, going off with its pathogenesis. Generally, for all the viruses, you have this primary viremia phase and secondary viremia phase. This is the general rule for all the virus you can write. Okay, what is this primary viremia and secondary viremia? Primary viremia is when the virus enters our human body, it goes first to the lymphoreticular system. Okay. Next, from the lymphoreticular, this going into the lymphoreticular system is the primary viremia phase. After, from lymphoreticular system, it spreads to the specific organs which it affects. So that is called as the secondary viremia phase. This is general rule for all the viruses. Here in measles, it has 4 phases. So 4 phases are, first one is incubation period. Second one is prodromal phase or prodromal illness. Third phase is this rash phase, that is called as exanthematous phase, and fourth is recovery phase. Okay, these are the 4 phases. So during the incubation period, this one, the measles migrates to the regional lymph nodes. It migrates to the regional lymph nodes. Next, this that is the primary viremia phase. Now it ensures that disseminates the virus to reticuloendothelial system. Next, secondary viremia spreads the virus to the body surfaces. That is the prodromal illness starts. Once the virus spreads from the this lymph node to the body surfaces or their body systems or body parts. Next, you get this prodromal phase. In the prodromal phase, the patient affected with measles will have fever, cough, coryza and conjunctivitis. Okay, after this prodromal phase, they will develop rash. So I will tell you the clinical features and its sequence of the disease, how it progresses. Okay, first you remember this one for your pathogenesis. Next, for pathology, when you see through the histological slide or histology wise, what you can see, this what is this, measles, a measles virus. Now this can cause infection or the necrosis of respiratory epithelium. So this causes necrosis of respiratory epithelium, and it also causes lymphocytic infiltrate. That is usual in all the diseases. Next, this can also produce small vessel vasculitis. It produces small vessel vasculitis on the skin and the oral mucosa. Since it produces small vessel vasculitis on the skin and oral mucosa, we develop rashes. Okay. When you see in a histology slide of this rash, you will appreciate the giant cells. So what is this giant cell? This giant cell is made up of intracellular edema. So once the virus infects the cell will swell. That will cause intracellular edema. Along with that, there will be giant cells will be along with that, they will form a giant cell will be formed with the help of 100 nuclei. So all these infected cells will together unite to form this giant cell called as, this is the one more of your MCQ question. Warthin-Finkeldy giant cell. Okay, Warthin-Finkeldy giant cell. One more time I will repeat. So this, in pathology wise, it causes necrosis of respiratory epithelium, and small vessel vasculitis will be present in the skin and the oral mucosa. When you see the histology slide of this rashes, you will appreciate a intracellular edema of the cell. Along with that, you will see the giant cells. What is this giant cell meaning? The fusion of all the infected cells, it will form this giant cell. Nearly around 100 nuclei will be present in it. Okay, that is called as Warthin-Finkeldy giant cell. This is about the pathology. Next, we will see about the clinical features and the sequence of event. This is very important in your short notes, also in your Viva session, and also in your MCQ question, because this sequence can be asked as a clinical question. Okay. So from, I'll write it here, day 1 to day 3. The patient will develop prodromal features. So I have told you the prodromal features, right? Fever with cough, coryza, and conjunctivitis. Okay, next, from day 2 to day 3, again the patient can develop the pathognomic feature of the measles, Koplik spot. So what is this Koplik spot? It will be like a rice grain appearance. White color spot will be there, which is surrounded by this erythematous margin. Okay, it is mainly present location. It is mainly present in the buccal mucosa. It is mainly present in the buccal mucosa opposite to second lower premolar. Okay. This is a specific question that is asked in your MBBS Viva session also. Okay. Next, where other than buccal mucosa, where these Koplik spots can be present. This can also occur in the lips, tongue, and hard palate. Okay, this can be an extra question. All of the following are true regarding Koplik spot, except this can be asked. Okay, so you have to remember this. Next, on day 4. On day 4, your rash develops. The rash is called as maculopapular rash. Maculopapular rash is the rash that develops on the day 4. How it starts? It starts from the face, that is mainly behind the ears. It starts mainly from behind the ears, then it spreads to face, then to the trunk. Okay, then to your whole extremities. Okay, so this is about the sequence of your disease, clinical features, how this measles progresses. So onset of rashes from day 4. Okay, only when the rash is developed, there will be production of antibodies. Okay, next. So this is about the course of the disease. And another one more thing, this measles have a very high, with the measles person is a very contagious person, so he have to be isolated, because the secondary attack rate of measles is 90% Whereas in chickenpox, varicella, secondary attack rate is 80%. This is in varicella and this is in measles. Okay, this one you have to remember. Next, the most common acute complication. The most common acute complication of measles is otitis media, while most severe complication is bronchopneumonia. In this, why? Because bronchopneumonia, the measles will make the person immunosuppressed. Okay, because it attacks mainly. I should have told you in pathogenesis itself. It mainly attacks the cell receptors CD150 and PVRL4 receptor that is present in the epithelium of respiratory tract epithelium. When it attacks these two receptors, this leads on to a prolonged immunosuppression. It leads to prolonged immunosuppression state. So once the patient leads to prolonged immunosuppressed state, they will be easily infected by all the bacteria and viruses. So they will get bronchopneumonia. Here we have two types of bronchopneumonia. One, because of secondary bacterial infection. So most common bacteria that will cause bronchopneumonia in child affected with measles are: one is Staph aureus, second Streptococcus pneumonia, third H. influenza. Next, or this measles virus itself can cause bronchopneumonia. So that type of pneumonia is called as giant cell pneumonia. Here the agent is measles itself. Okay, so this is about the complications. And another one is most acute complication, most severe complication. Next is chronic complication. So the chronic complication is SSP. This is also another 1 mark question, MCQ question, that is subacute sclerosing panencephalitis. Okay. Next question, next 1 mark question that can be, this is another 1 mark question. The next 1 mark question that can be asked is, among the symptoms which will last longer. So among the prodromal symptoms or among the rashes which will last longer. So among the symptoms that is present in the measles, cough. It lasts longer up to 10 days. Okay, this can also be a exam question or viva session question also. Okay, the most common cause of death in measles is pneumonia. That is also another question. The most common cause of death, not measles itself, it is pneumonia. Okay, next you have another entity called as modified measles infection. So what is the meaning of modified measles? Modified measles infection. This is, it is not a highly contagious one. Modified measles is not a highly contagious one. It is an infection in patients with a passively acquired antibody. That is the patient who have received vaccination, that is MMR vaccine. After that, the patient is being acquired measles infection. They will have this modified measles. That is, their severity will be reduced and they will not be highly contagious. So that is called modified measles infection. That is infection in patients with passively acquired antibody. Okay, that is called modified measles infection. This one you have to remember. Okay, this is about measles infection. Next, you can ask about lab investigations. So, but measles is clearly a clinical and an epidemiological diagnosis. That one you have to remember. It is a clinical and epidemiological diagnosis. But when you go for the lab investigations, if you take a CBC, you will see in acute phase In acute phase, you can see a low TC, that is low WBC count, with lymphocytes being more reduced. Lymphocytes being more reduced than the neutrophils. Okay, so this is about measles. But you can, when you want to confirm whether the patient having a measles or not, you can do this antibody investigation, that is IgM antibody can be done in the blood sample of this patient. IgM antibody can be done in your after when you have to do this disease, that is after the patient has acquired rash, that is 72 hours. Within 72 hours of patient have acquired rash, you can send for IgM antibody, or after that you wanted to send means you can send it for IgG antibody, but you have to need a serological titer should be doubled, so that you have to send IgG antibody titer at 2 to 4 weeks interval also. Okay, so this is about the measles. Next we will discuss about the main topic, that is SSPE. This is also a separate question for you, that is subacute sclerosing panencephalitis. So what is subacute sclerosing panencephalitis? It is a chronic infection or a chronic complication of a patient who have acquired a measles in their earlier days. So this is a persistent infection first. Next, it occurs after 7 to 10 years. It occurs after 7 to 10 years. Here, the virus has regained the virulence and it attaches to the cells in CNS, and it can cause symptoms of this encephalitis. Okay. So, actually the virus has 6 proteins. Okay, measles has around 6 proteins. But during this SSPE, no, this measles which is have been persisted in the patient will undergo mutation and it will have 5 proteins. Okay, so when it is 5, there will be it will be called immature virus or immature product will be present. This immature product has an ability to move in the neurons, so it has the ability to attach to the nerve cells and present in the brain, that is leading to encephalitis. So in a simpler way, you can tell the defective virus or the mutant virus that is leading to this is called SSPE. Okay, it is also known as Dawson disease. Okay, subacute sclerosing panencephalitis is also known as Dawson disease. Here we have 4 stages. There are 4 stages, starting off with the stage 1. The stage 1 is often missed. Here the patient will present with fever and headache. Next, in stage 2, the pathognomic hallmark for this stage 2 is myoclonic seizure. The patient will get myoclonic epilepsy. I have seen a child with SSPE in our ward. Here the child will present with myoclonic seizure, that is the child will have jerks. He will fall annoyingly to him, that he is having seizure. Okay, so he is present with myoclonic seizure, that is a hallmark, and patient will have involuntary movements. If possible, I will show the video of the child. Will have involuntary movements and repetitive myoclonic jerk will be present. Okay, this can occur both in the axial and the appendicular muscles, not specifically to one group of muscle. It can occur in both axial and in the appendicular muscles. Okay, this occurs because of inflammation in the deep brain, inflammation in the deeper part of the brain, that is in the basal ganglia. Okay, next in the stage 3, this seizure, myoclonic seizure or this involuntary movements will disappear. This involuntary movements, this is replaced by chorioathetosis. Okay, next dystonia and lead pipe rigidity. Okay, then finally the sensorium will, in this third stage itself, the sensorium will deteriorate and the child will go on to coma stage 1. This is in stage 3. In stage 4, there will be loss of critical centers that support breathing, heart rate and blood pressure. So there will be a loss of the critical centers that supports breathing, heart rate and blood pressure. So it will ultimately lead to the death. Okay, these are the 4 stages in SSP. Next, how we are going to diagnose this? Diagnosis is through the CSF analysis. In CSF analysis, you have to look for measles antibody. Okay, that is both IgG and IgM, both will be elevated in this one. Next, EEG findings. There will be a characteristic EEG finding in a patient with SSP. The characteristic EEG finding is called as Rademacher complex. It is called as Rademacher complex. That is, there will be a periodic high voltage with a slow background. So there will be a periodic high voltage with or on slow background. This is specific for SSP. Okay, you have to remember this. Third one is histological finding. That is, during the biopsy of the brain, you can isolate the virus. So isolation of virus or the viral antigen in the brain tissue. But this is not being done. This too is enough to confirm the diagnosis of SSPE. Okay, what is the treatment for SSPE? But anyway, the child will go on to ultimately, whatever treatment you give, the child will ultimately lead on to death. But 30 to 34% there is a chance of improvement when you started the treatment with isoprenosin with or without interferon. Okay. Next, but main treatment here, this will be second one, but the main here will be primary treatment is supportive, is always the supportive management. For myoclonic seizures in patient with SSPE, the drug of choice will be carbamazepine. Okay, so this is about the treatment for a child with SSPE. Treatment for a child with measles is always the supportive management. Okay, thank you. We will discuss about next virus in our next session. Thank you.